Hello, everyone. Good afternoon. Thank you for being with us. So looking at this slide, this kind of provides some of the why of what we're doing with this measure. But essentially, we're wanting to manage acute onset severe hypertension as defined as a systolic blood pressure greater than or equal to 160 millimeters of mercury or a diastolic blood pressure greater than 110 millimeters of mercury. And obviously, this is going to be occurring during pregnancy or in the postpartum period. And this could be from new onset of hypertensive disorder in pregnancy or worsening chronic hypertension. And so we care for both of those situations. And ultimately, if that blood pressure is an isolated blood pressure, there's nothing that needs to be done. However, when you have a severe range blood pressure as defined above, and then within a 15-minute time is repeated and is persistently severe, that's when we're encouraging and trying to promote the active management of that acute onset severe hypertension. The reason why we care so much about this is that hypertensive emergency increases the risk of stroke, and in fact can be related to approximately 2/3 of the causes of stroke, leading to maternal mortality as well as severe morbidity. So ultimately, as mentioned, when you have a severe range blood pressure, we want you to repeat their blood pressure within a 15-minute time frame. If it remains in the severe range, the goal from that point is to treat with an antihypertensive medication within 1 hour from that finding. There's 3 first-line options for you to choose from: IV labetalol, IV hydralazine, and oral nifedipine. All of these are available as an ACOG committee opinion. You can reference that. It's number 623, and it was published in February of 2015. And ultimately, the goal is to get their blood pressure into the 140 to 150 systolic range and or 90 to 100 diastolic range. Ultimately, we don't want to treat them too much and drop their blood pressures below that, as that may cause relative hypotension, which could cause and lead to adverse fetal effects in terms of your fetal heart rate tracing, specifically late decelerations in Category 2 fetal heart rate pattern. And the overall goal is to prevent hemorrhagic stroke with all of this. And what you'll see on the next 3 slides are basically those protocols that are provided by the American Congress of Obstetrics and Gynecologists, and they have been nice enough to produce this information for us. And these are all 3 great protocols to follow. And it's just up to you all to decide which one you should choose: IV labetalol, IV hydralazine, as seen on this slide, and then finally oral nifedipine. All of them are felt to be equally efficacious. For me personally, I would promote the use of oral nifedipine because, number one, it is an oral agent and it does not require an intravenous access. So particularly when these patients are coming into us through the emergency department or acutely in the clinic, this is someone that would not require an IV be placed prior to treatment, which may or may not help decrease the amount of time from diagnosis to the initiation of therapy. So for me personally, I like oral nifedipine because of that. Additionally, the side effect profile of oral nifedipine to me is a lot less than I see with IV hydralazine or IV labetalol. So for me personally, I like oral nifedipine as my first go-to agent. But you can see, if you're not getting a good response from the oral nifedipine, the standard approach then is to introduce in IV labetalol or hydralazine in those situations. So I'll turn it back over to Barbara so she can describe to us what's happening in Oklahoma.
So just a little bit of information about what we're seeing with our AIM data portal and the data that you all are entering. We see regarding the structure measure of hypertension treatment, and this is related to severe hypertension and preeclampsia, that approximately 54% of Oklahoma hospitals have a protocol in place, and that it does support the treatment of the severe hypertension. So only half of our birthing hospitals. When we look at the process measures, two of those are related to education for nurses, and you can see that about 65% for both of those measures are in place in our birthing hospitals, education for nurses on preeclampsia in general, and education for nurses on the bundle and your hospital's protocol. For providers, for physicians, we can see it's much less, that only 37% of providers have received the overall education, and the education on the bundle and protocol, about 45%. When we look at timely treatment, the process measure there, we see approximately 50% of our women are being treated within 1 hour. And this information is gathered from our data portal. So we want to make sure that there are, and we'll discuss this here at the end of our presentation and discuss what your barriers are and how we can help support these women getting severe hypertension treatment. When we look in Oklahoma, what we're hearing, and this really isn't in Oklahoma, there are other states that are looking at this through AIM. There are now eight states that are in the initial cohort for AIM states. We are the first one. And across the board, all of these states are seeing that we are not recognizing these patients with severe hypertension. This could be poor technique in blood pressure measurement. We're seeing cases where they're not being rechecked within 15 minutes. So as Dr. Smith mentioned, anytime you have a blood pressure that is in the severe range, either 160 or 110 or greater, they need to be rechecked, and if it's still severe, they should be treated. If it's not still severe, I would certainly recommend that that patient needs heightened surveillance. We don't want to treat somebody who just had some kind of errant blood pressure that was in the severe range, but it was not correct. It was just a one-time thing. But we certainly do want to keep a close eye on women that would have a blood pressure near or within this range. What we're seeing most of all is just a hesitancy in treatment, either explaining away or failing to believe the blood pressure. Maybe it's right on the borderline. I think we're pretty comfortable treating when it gets up to 180 or so, but 160, a lot of times what we're hearing is there is, well, let's just wait and see what happens with it. Where we want to really replace that mentality with go ahead and treat it. There has been evidence recently that shows that it is the systolic range that is the most significant indicator for stroke. So those systolic blood pressures that were 160 or greater, that puts the woman at the most risk for stroke. We also see the inadequate response. As I mentioned, waiting to start antihypertensive therapy, not having a protocol in place to follow, incorrectly using magnesium sulfate as an antihypertensive. We hear that a lot. Well, we give our women magnesium sulfate. Well, that is to prevent her from having seizures. It is not an antihypertensive medication. So if she is preeclamptic, you do need to give magnesium sulfate as well as an antihypertensive therapy. Also, we've heard that it can be difficult to obtain the needed medications. If these women, they may not be admitted as a patient, and so it can be difficult. So we want to hear about that when we're having our discussion. But I think the main mantra we want you to hear is believe it and treat it. So when you get those blood pressures, don't say, oh, well, she's in pain, or she walked up the stairs. That does not put women into a severe range. And it really doesn't matter why they're in the severe range. If they're in that range, they're at an increased risk for stroke, and we need to treat the blood pressure. The other thing that we're seeing is data issues with this measure. And again, it's not just in Oklahoma. We're seeing this all over in all of the different states. So clinically, you can use your judgment that I'll give two examples that we've had recently. A woman that was in a severe range with her first blood pressure, and then a second blood pressure was 159 over 102. So from a data perspective, that can require a more strict approach. Should we include this woman in our denominator? It technically is not 160, but what do we do when we can't, if the clinical data does not exactly fit the data measure? So Dr. Main, you all know that Dr. Elliott Main from California, and in California they've already done a lot of work on this. He was one of the authors of the bundle, and he wants us to have that overall philosophy that if the woman should have been treated in your clinical judgment, then go ahead and include her in the denominator. Or, for example, you have a situation of a woman, and we had one hospital that said there was a patient with a blood pressure of 172 over 106. They did not retake a blood pressure for an hour. So they didn't have the second blood pressure. But I think everyone would agree that we needed to do something. You should have done a follow-up blood pressure. She likely would have received treatment. So if you believe that something else should have been done, then include her in the denominator. Because technically, if you had a lot of those women, if you were never retaking their blood pressure, none of them would be included in your measure. So this data is to help you see what the issues are in your hospital. It is not data that is related to reimbursement. Nobody is coming back to you to look at to monitor your data. Yes, we are comparing it with our hospitals. It is de-identified, and soon we will have other states that are entering their data into the data portal, but we want you to be honest, and if you decide that this woman should have received treatment or should have had a follow-up blood pressure, nothing was done, then include her in the measure. So again, the purpose is to drive improvement. Your hospital needs to look at what are your issues, what are your barriers, and how can we solve them. So if the cases are not included, then we cannot adequately evaluate the situation at the hospital level, at the state level, and soon to be at the national level. So we want to make sure that all of these women are included in your data. We understand that gathering this data is difficult, that it does require some kind of abstraction, so it can be time intensive. When you look at the measure, they do recommend 2 data sources. And here are some that we have heard of other hospitals in Oklahoma and other states, either using an EMR search for blood pressures in the severe range, if you're capable of doing that, looking at diagnosis codes related to hypertension and preeclampsia, and then abstracting those records, or crossing them with a pharmacy log. Who received those severe hypertension meds? Who received magnesium sulfate, looking at your medication dispenser to see who had those medications dispensed to them. One thing that we think, too, could catch a lot of these is looking at your delivery log or a real-time log on the unit. And we do have a tool for that on our website where you can keep track either by shift or by day what women had severe hypertension. You all may have some others, and so if you do, we're almost to our discussion time, and we would encourage you to share those and any issues you have with these data sources. We do recognize that this does take time, and that's something that hopefully as we get into this more, it will become more of your workflow. Kind of the same issue with every week counts. At first, it's kind of hard to gather the data, and it can be confusing, and it takes time to learn and figure out a process for your hospital. But once you get that into place, it becomes easier and flows a little a little better. So we think that will happen with this issue, and we want to hear from you and see what we can do to help. The other, go ahead, let me put that. So I'm going to open up the phones here and let you all discuss. We have Dr. Smith with us, and he can talk about any clinical issues. I'm happy to talk about data issues.
I'm even happy to reach out to them if you provide contact, or if they want me to contact them, I'm happy to talk with them on a separate occasion as well. So I think the real goal is, again, try to increase that treatment, and that's almost why I prefer to go with Nifedipine, just because the side effect profile is very minimal and very unlikely that you can cause significant hypotension from just one dose of oral Nifedipine. Unlike IV hydralazine and or labetalol, which I personally have seen one dose cause significant hypotension. So that's kind of what I encourage everyone to do.
Yeah, I also will say, Evelyn and others, AIM group, setting up a webinar that will be all access, available as a recorded webinar on their website with the two authors of the report that came out from ACOG, and they will be addressing this, looking at what responses to treatment, as Dr. Main told us on Friday on a separate data call. They looked at, like Chad mentions, the hypotension, and even if they had hypotension, was there any related fetal response? And they really only saw that in less than 1%. So having high blood pressure is significantly greater than the risk of treatment. And that's what we really want to move to, that mentality, instead of being resistant to treat, that we should be willing to treat pretty easily. So that's, I think it's going to take time to change. I was thinking about like skin to skin, something that we started probably, if we would have looked at hospitals 6 or 7 years ago, I bet hardly anybody was doing skin to skin. And now everybody's doing the skin to skin. So it's going to take years, probably, hopefully not, as we're shining the light on this, but we will address it. And as Chad said, he's even available to come to your OB medical staff meetings, and we're going to put out an invitation if people want that to happen. Depending on where you are, it might be via video conference or telephone conference, but some of them it's pretty easy to go in person and talk to your providers about this issue. And then hopefully when we get the webinar recorded, which I think is going to be done here within the next couple of weeks, we can also refer the providers to that, and that will allay some of their fears or just hesitancy in treatment.
St. Francis, we have had Epic build us 3 reports for hypertension and for postpartum hemorrhage. So whoever that was, if she wants to contact me, I'd be glad to talk to her.
How about can you send that? I don't know if you're able to send those, Lisa, but I could share them with everyone.
I can send the criteria of what they built and how they pulled the data. So like the parameters that they use to build the report.
Right.
I can do that.
Yeah, if you would send that, and I'll just share with everybody else, and then maybe they could contact you if they have any questions. Would that be okay, Lisa?
Yeah, that'd be fine. It has been a lifesaver, but it is very time-consuming, but it's made the process much quicker.
Right.
Thank you.
Yeah. In some of the facilities that we've been, one of the issues that comes up is oftentimes these providers are being contacted when they're in the middle of a busy clinic. And so from what we hear, the communication is often, Dr. So-and-so, we want to talk to you about your patient in room 15. She just had 2 severe range blood pressures. Is there anything that you'd like to do at this point? And to a physician that's in clinic and busy, they may not immediately jump to the fact that, oh, there's an initiative to treat that severe range blood pressure. And so one of the techniques that I think may be helpful in that specific instance is when having that communication from nurse to physician, really having the nurse prompt the physician similarly to the following. Dr. Smith, your patient in room 15 has just had 2 severe range blood pressures, and at this point it's recommended that she receive an antihypertensive. What would you like to order at this time? And so instead of leaving it for more open interpretation from the physician, kind of prompt them along the lines of, hey, this initiative exists, and instead of asking them what they want to do, ask them what hypertensive agent they want to give. And that may be helpful, again, but it's for that one specific situation.
The other thing, when we talked about the provider education, they're like, I know about preeclampsia. I don't need to receive education on it. And, that may be true. I'm sure they were educated on it, but this report does talk about the most recent evidence, and it is a very well-done report. And on our website, we do have the e-modules. They're actually on the AIM website, but we link to them on our website. And they're short little videos that each one lasts less than 10 minutes. And they also are in the format of the bundles with the readiness, recognition, response, and reporting. So that can be something that, I don't know if many hospitals are hesitant to require their providers to do that, but you do get a certificate when you watch the video. So Dr. Smith can talk about those too, and hey, this is something we're measuring, and I know at the national level, even SMFM is pushing their providers to, do these education modules. Yes, we understand you received education, but let's do these so you're up to date on what's happening with the latest information related to severe hypertension. So that is another thing, and if anybody is interested in having Dr. Smith come out to your hospital or talk to them, via telephone, you can email me and we can arrange that. So I think that it's going to take time for people to be aware, but that's one of the things in your hospital. You can figure out what are some ways that we could help this happen and move it along. I will tell you, too, one thing that is very exciting is that providers are, one of the things that really drives them is their maintenance of certification. And I just received last week an application that we can use to the American Board of Obstetrics and Gynecology, that if you are participating in these quality improvement efforts within your hospital, and your hospital is in an AIM state or an AIM system, then you can receive MOC something, category 4 or something?
MOC 4.
MOC 4, so that, we're going to get that process rolling, and that hopefully will be something that providers that could motivate providers to, I don't know how they're measuring participation. I haven't read it all yet. But that could be something that would be helpful as we move forward.
Mm-hmm.
So we'll be working on that to submit it to ABOG. One other example I wanted to share was that we had a hospital that the blood pressures were less than 15 minutes apart. So they weren't including that woman in the measure. 15 minutes is just a guide that you want to take it within 15 minutes. So take the first one. I would suggest get things moving along to get ready. Take the second one. If she's still high, go ahead and treat. You don't have to wait for 15 minutes. I think the purpose is just to ensure that that first severe reading is a valid blood pressure. So, again, like we said, if you are abstracting these charts, look and see should something else have been done, and go ahead and treat her. Go ahead and include her if you think that she should have been treated. Let me show you our references on the next slide just so you have these available. If you care to look at these, the committee opinion is free access through the ACOG website. The report on hypertension, I'm not sure if that is free through the website, but you can ask us if you do not have it. All of the council's bundles are available, free access, and then the AIM data measures also. Everything on the Safe Healthcare for Every Woman website is available to everyone. So these are the references that you can use. And if you have any other questions or need to share anything else, let us know. So thank you all for joining us, and have a great day.